request Dr. Manju Anup, working at Giridhar Eye Hospital as a glaucoma consultant. She will be speaking on management of acute angle closure glaucoma for optical outcomes.
A very good morning to all. Thanks, Anjana, for the invite. I'll be talking on the management of acute angle closure glaucoma. What happens here is there will be a sudden obstruction of the aqueous outflow through the trabecular meshwork leading to raised intraocular pressure. It's an ophthalmic emergency. So now we'll go on to the pathophysiology. What are the mechanisms involved? The first one is pupillary block. Here a functional obstruction happens at the pupillary plane between the iris and the lens. So the aqueous collects behind in the posterior chamber and the iris pushes forwards and it closes the angle. The next is plateau iris configuration. Here there is an anterior insertion of the iris onto the ciliary body, and because of this, when the pupil gets dilated, the angle gets obstructed. In case of ciliocoroidal effusion, there will be ciliary body edema and anterior rotation of the ciliary body. So there will be entire iris lens diaphragm will be pushed forwards, and this in turn lead to angle obstruction. In aqueous misdirection, the same mechanism. Because of the posterior flowing of the aqueous, the entire iris lens diaphragm is pushed forwards. Now moving on to the etiology. First one is pupillary block. It happens in acute primary angle closure glaucoma, secondary to iris bombay, secondary to inflammation, uveitic or in silicon oil filled eye, anteriorly subluxated lens, drugs causing mydriasis, then microspherophakia. Plateau iris configuration in plateau iris syndrome. Ciliocoroidal effusion happens in inflammatory conditions like VKH or scleritis. Then drugs causing ciliocoroidal effusion, the most common is topiramate. Even diamox can cause ciliocoroidal effusion. Then tumors or cyst, and then aqueous misdirection. Symptoms and signs, I'm not going into the details as you all know the presentation. Then diagnosis, you need a detailed history to know the drug intake, whether any history of drug intake. They may not reveal when they come with the acute episode. Then you have to do a visual acuity and refractive error to see, to know the etiology. Then slit lamp evaluation, intraocular pressure, gonioscopy, undilated fundus examination. Sometimes you may need other tests like UBM or B-scan to confirm your diagnosis. Then coming to the management, the primary aim is reduction of intraocular pressure. You can use oral and topical anti-glaucoma medication. To control the inflammation, you have to use topical or sometimes even oral steroids. Then you have to manage the underlying pathology. So now look at some cases. This is a 64-year-old female who presented with acute onset of headache, nausea, and the right eye pain, redness, watering, and diminution of vision for 1 day. This was her presentation. On examination, the right eye uncorrected visual acuity was counting fingers 3 meters with typical signs and symptoms of acute angle closure like conjunctival congestion, epithelial edema, shallow AC. Lens was cataractous, mid-dilated fixed pupil with glaucoma flecken, hazy view of the disc. Her intraocular pressure was 62 millimeters and the gonioscopy differed in that eye. However, the other eye gonioscopy showed occludable angles. So here the diagnosis is acute primary angle closure glaucoma, and the mechanism here is pupillary block. So you have to reduce the intraocular pressure first, for which you can use oral and topical anti-glaucoma medication. Once the IOP reduces, you have to break the attack and give pilocarpine eye drops. And as soon as the media is clear, you have to do a laser peripheral iridotomy. And post-operatively, you can treat with steroids and the anti-glaucoma medications as required. Second case, it's a 68-year-old female presented with acute onset headache, nausea, with right eye pain, redness, watering since 1 day. This was the presentation. This picture was taken on the next day when her pressure reduced. On examination, her uncorrected visual acuity was hand movements and the conjunctival congestion, epithelial edema, shallow AC, and the lens was showing mature cataract, mid-dilated and fixed pupil. There was no view of the disc. Intraocular pressure was 56 millimeters of mercury. Other eye was pseudophakic with CD ratio 0.4 and the angles were open. So this was a case of lens-induced acute angle closure, and here also the mechanism was pupillary block. So again, reduce the intraocular pressure and then steroids, laser peripheral iridotomy. I prefer to do an LPI before the cataract surgery if the pupil is constricted. If it is in mid-dilated fixed stage, maybe you can even go in for a direct cataract surgery. The next case is a 42-year-old female who presented with acute onset of diminution of vision, both eyes, since 2 days duration. And this was her presentation. On examination, her uncorrected visual acuity was counting fingers 3 meters in both eyes, which was improving to 6 parts with -3 diopter sphere. And however, the patient was not having any vision problem previously, and she was not using any glasses. Conjunctiva was showing mild congestion, cornea was relatively clear, AC was shallow, and the pupils were round, sluggish. Disc was healthy. Intraocular pressure was 46 and 48 millimeters, and the gonioscopy revealed closed angles. It was a very convex iris, and I couldn't even indent and open. So, looking at the picture, which is not very very much, it is not like acute angle closure attack. I asked about the history. Then she told she is on treatment for migraine and she is on topiramate 25 milligram per day since 3 weeks. So here the diagnosis is a drug-induced and acute angle closure, and the mechanism is posterior pushing. That's why she got myopic shift in refraction. We did a UBM to confirm the ciliocoroidal effusion, and here the management, again you have to reduce the acute IOP rise with topical and oral anti-glaucoma medications, and she was started on steroids. Sometime, most of the time it will get away with only the topical steroids, but sometimes depending on the extent of effusion, you may need a systemic steroid. Atropine cycloplegics plays a major role, and the most importantly, you have to stop the offending drug. And in 5 days time, her AC was deepened, and in 2 weeks, it was back to normal, even the ultrasound. This was a case of 64-year-old female who presented with acute onset left eye pain, redness, watering since 2 days, and this was her picture. Her uncorrected visual acuity was 660, which improving to 69 parts in the left eye. Conjunctiva was showing diffuse scleral congestion. Cornea was relatively clear, shallow AC, cataractous lens, round and sluggish pupil, and the disc was showing edema. Her intraocular pressures were 42 millimeters, and the gonioscopy revealed closed angles in the left eye. However, the angles were open in the right eye. So, considering this as a scleritis, we did a B scan and noticed the fluid T sign. And here it is an acute secondary angle closure, again because of the posterior pushing mechanism. The management is same as in the previous case, and she was treated for scleritis with oral and topical steroids, with cycloplegics also given, and in about a week's time her AZ deepened and angles became open. Coming to the last case, this was a 54-year-old male who had undergone phaco-vitrectomy with silicone oil 10 days back. He presented with acute onset of left eye pain, redness since 1 day. This was the presentation. On examination, the uncorrected visual acuity was counting fingers 2 meters. Conjunctiva was showing some congestion. There was some amount of epithelial edema, but the AC was showing iris bombay. The lens, it was a pseudophakic eye. Pupil was less than mid-dilated because the patient was already on homite. Disc details were not clear because it was an oil-filled eye. Intraocular pressure was 43 millimeters, and gonioscopy was deferred in this case. In this eye, and the other eye it was open angle. So here the mechanism is again pupillary block, but it is due to acute secondary angle closure, which was inflammatory in this case. So I gave Diamoxstat, then topical anti-glaucoma medications, and then since the view was a bit clear, I did a PI on the same day, And here the thing is, as soon as you do the PA, there will be an aqueous flow into the anterior chamber, and iris flattens immediately. And these patients may need a more frequent steroids, otherwise this PA may get closed again. I have even done 4 to 5 times PA in these cases, oil filled eyes with iris Bombay. So to conclude, reduction of intraocular pressure is the first line of treatment in acute angle closure, regardless of the underlying etiology. It's critical for the clinician to distinguish the underlying mechanism, as the treatment protocols are markedly different. The definitive treatment for pupillary block is laser peripheral iridotomy. Prophylactic LPI should be considered in other eye if occludable angles. In secondary acute angle closure, additional treatment is determined by the cause, and you have to make sure it's very important that prompt and proper management helps to prevent irreversible optic nerve damage. Thank you.
Thank you, Dr. Manju, for that wonderful talk.